Hello everyone, my name is Ivan Velickovic. I am obstetric anesthesiologist at Kings County Hospital, that is a part of New York City Health and Hospitals. I have no conflict of interest to declare. I work in Brooklyn, and the hospital where I worked is marked with an H right in the center of the screen. Physician affiliated group of New York actually has around 5,000 physicians, and we provide the care for about 1.1 million New Yorkers. There are about 43,000 healthcare professionals, and our patients speak more than 200 languages, and they can get a service in their native languages. And before we go about dexmedetomidine, I just want to show you the environment where I practice. So this is the labor and delivery room. We have 8 rooms like this in a hospital where I work. This is the patient bed that actually transfers to the delivery bed, so patients deliver in these beds. To the left of the patient bed are the infusion pumps that are used for most commonly oxytocin, for magnesium, any other drug if it's needed. Even more to the left, it's the epidural pump that we use every day for the epidural medication. And even to the very left of the screen is the neonatal table equipment that is used for the resuscitation of the babies when babies are born. On the other side, to our right or to the left of the patient, is the equipment for monitoring the fetal heart rate tracing and a big computer. And this is how it looks from the other side. Through the window you can see competing hospital. I used to work there for a long time. You can also see the sofas for the family members, because family members are always welcome and they stay with the patient all the time, even during the delivery process. This presentation is, however, about dexmedetomidine, and as we all know, dexmedetomidine is a highly selective alpha-2 adrenergic receptor agonist with sedative, anxiolytic, and analgesic properties. We started using dexmedetomidine long time ago. It received the FDA approval in 1999 as a sedative for mechanically ventilated critical patients, and in 2008 for procedural sedation for non-intubated patients. The Europeans were about 10 years behind us. So the European, when it comes to the approval of the dexmedetomidine, the European Medicine Agency has approved the use of dexmedetomidine for sedation in adult critical patient in 2011, and awake procedural sedation in non-intubated patient in 2018. So this is a relatively old drug, so it's going to be 30 years that we have dexmedetomidine. So why talk now about the spinal epidural use in the obstetric anesthesia? Well, at least in the United States and probably elsewhere, the price of the drug is quite important parameter when it comes to how widely available the medication is. And for a long time, dexmedetomidine was very expensive. So despite the fact that we have it available, we just didn't have the option to use it in a spinal and epidural space, but that stuff has changed several years ago, and now the new knowledge is coming almost every month, and new studies are just coming. So that's why we have this presentation. Dexmedetomidine has demonstrated efficacy in enhancing the quality and duration of neuraxial anesthesia when administered in combination with the local anesthetics. Despite its advantages, neuraxial administration during labor and cesarean delivery remains off-label in United States. Clinical pharmacology. Dexmedetomidine, compared to clonidine, is more selective alpha-2 agonist with higher affinity for alpha-2 receptors. Alpha-2 to alpha-1 affinity or a ratio is 1,620 to 1 with the dexmedetomidine versus clonidine where it's 220 to 1. Dexmedetomidine's higher alpha-2 selectivity explains its increased sedative and analgesic effects as central alpha-1 adrenoreceptors activation counteracts the alpha-2 hypnotic effects. Preclinical studies that were done on rats and rabbits have demonstrated that dexmedetomidine dose-dependently produce lidocaine-induced anesthesia. Clinical investigation have confirmed improved block characteristics and a reduced postoperative pain score in obstetric populations receiving epidural dexmedetomidine as an adjunct. No pharmacokinetic interactions between dexmedetomidine and isoflurane, propofol, alfentanil, and midazolam have been demonstrated. However, due to possible pharmacodynamic interactions, dexmedetomidine, when co-administered with this medication, a reduction in doses of dexmedetomidine should be done, or the reduction in doses of these anesthetics, sedatives, or hypnotics or opioids may be required. ASA guidelines. When it comes to what does the ASA says about the dexmedetomidine, ASA meaning American Society of Anaesthesiologists. Current American Society of Anaesthesiologists guidelines address only systemic, meaning intravenous use. ASA guidelines supports the use of dexmedetomidine as an alternative to benzodiazepine sedatives for moderate procedural sedation and analgesia. In 2024 statement on adjuvant medication during the cesarean delivery, the ASA lists dexmedetomidine as a second-line agent that provides maternal analgesia and anxiolysis. The ASA guidelines suggest considering dexmedetomidine with careful monitoring for maternal bradycardia and hypotension. Recommended dosing regimen. For cesarean section, the literature says doses of 3 to 5 micrograms intrathecally are commonly studied. In our practice in Brooklyn, we use 5 micrograms as a part of the spinal anesthesia. For cesarean section, when we use the epidural anesthesia, and when we most commonly, those are the patients that were already in labor, and then the labor is not progressing as planned, and then we need to convert labor analgesia to cesarean section. Then the literature supports the dose of 0.5 mics per kilogram given over 10 minutes. Mixing dexmedetomidine with local anesthetics usually results in a similar levels of the block when it comes to the height of the block. For labor analgesia, concentrations ranging from 0.2 to 0.5 mics per ml have been used in combination with ropivacaine. It can also be used with bupivacaine. Continuous infusion obviously needs to be adjusted based on a patient response. For a labor analgesia top-off, which basically means when we have the labor analgesia and patient is having a pain despite running labor analgesia, we have already given local anesthetic, but that doesn't provide the comfort to the patient. We already given fentanyl into the epidural space. Then we usually use 12 to 16 micrograms of the epidural loading dose given over 10 minutes. Dexmedetomidine can be even used if we provide the labor analgesia with a single shot spinals in places. We usually don't do it in the United States, but the single shot spinals are widely used around the world. So giving a little bit bupivacaine, a little bit of the opioid, and 5 to 10 micrograms of intrathecal dexmedetomidine can provide the labor analgesia for a good 3 hours, if not longer. Maternal safety profile. Is it safe for the mothers? The most frequently reported maternal adverse events associated with epidural dexmedetomidine are hypotension and bradycardia. These episodes are typically mild and transient and responsive to standard therapeutic interventions without evidence of serious sequelae in the published literature. What's kind of interesting, if you read some studies, they would say that they found higher incidence of hypotension, less bradycardia, and the other studies will show that they had more bradycardia and less incidence of hypotension. But even if they happen, they are usually easy to manage. Adverse effects were rare, but more common after intravenous than the neuraxial use. Pretty consistently, studies are showing that dexmedetomidine is associated with lower incidence of itching, of pruritus and shivering than opioid-based agents. Neonatal safety profile. So will it affect when we give it spinally or epidurally or even intravenously before the delivery of the baby? Will it affect the Apgar scores? Well, systematic reviews and meta-analysis have consistently shown that epidural dexmedetomidine does not adversely influence neonatal outcomes. The American Society of Anaesthesiologists notes that dexmedetomidine, when administered within recommending dosing parameters, has no documented effect on neonatal scores or umbilical blood pH. Breastfeeding and early lactation. Dexmedetomidine is associated with earlier initiation of exclusive breastfeeding, reduced time to first lactation, and greater early milk production without adverse effects on neonatal neurobehavioral outcomes or maternal safety. These benefits are likely mediated by enhanced analgesia, reduced anxiety, and improved maternal recovery. Contraindications. No absolute contraindications to neuraxial dexmedetomidine have been identified that are unique to the obstetric population. Caution is advised in patients with pre-existing bradycardia or advanced atrioventricular block owing to increased risk of maternal bradycardia reported in clinical studies. The U.S. Food and Drug Administration does not list pregnancy as a contraindication for dexmedetomidine. And before we start with the conclusion, I just want to emphasize again on who benefits most from spinal dexmedetomidine, epidural dexmedetomidine. Why should we give it to our patients? If your cesarean section lasts less than 2 hours, there is no need to give the dexmedetomidine. If your labor epidurals, with your labor epidurals patients are comfortable, there is no need to give the dexmedetomidine. However, If you think that your cesarean section may last 3 hours or 4 hours, spinal dexmedetomidine, 5 micrograms of dexmedetomidine will provide pain relief not for 3 or 4 hours. It will provide pain relief for 5 to 6 hours. Outside the obstetric anesthesia, if you are doing vascular or orthopedic case that you need a spinal anesthesia that might need to last several hours and you're afraid to use the combined spinal epidural and put the catheter due to the risks of bleeding, spinal dexmedetomidine will give you 5 hours, maybe even 6 hours of surgical block. If you have also, on the other side, if you have the epidural that's running 16 hours, 20 hours, 24 hours, and patients start getting uncomfortable, epidural dexmedetomidine will significantly increase the quality of labor analgesia. Also, if you're running labor epidurals for maybe 12 hours, 16 hours, and then the patient needs a cesarean section, then adding dexmedetomidine together with the local anesthetics will increase the quality and density of the block. And our practice nowadays is significantly different than it was a year or 2 years ago. So it is very likely that the use of dexmedetomidine will significantly increase in the future. Even the European prospect guidelines are talking about the dexmedetomidine. There are basically 3 studies that I want to briefly mention. This is the first study that came in regional anesthesia and meta-analysis in March of 2025, and this was the first big US-based study on spinal and epidural dexmedetomidine, and that actually prompted us. At that time I was at Yale to start giving it to our patients. I would recommend everyone to look at a study published just a few months ago in the Anesthesiologist that specifically address all different adjuvants that can be given as a part of the spinal anesthesia, and this study is published in Anesthesiology. And probably, if you are interested specifically for the OB anesthesia, this is the study by the Ruth Landau, one of the most famous obstetric anesthesiologists in United States, and this is published in International Journal of Obstetric Anesthesia, and that's probably the best article on the use of the dexmedetomidine in obstetric anesthesia. These are the conclusions from a Ruth Landau article, and I agree with 99% with what's said in this article. So, dexmedetomidine will decrease the incidence of the shivering, increase the onset of the epidural block for the cesarean section significantly, spinal block maybe a little bit, will significantly increase the duration of sensory and motor block after the spinal anesthesia, and to a certain extent after the epidural, will decrease the intra-operative pain, will have a relatively little effect on intraoperative blood pressure. It may give you some intraoperative cessation, likely will not influence the nausea in vomiting. It might decrease the itching, will significantly improve post-op pain. You will need way less medication post-operatively, and as the matter for future research, we have to see its effects on the wound hyperalgesia, postpartum depression, and long-term maternal outcomes. It will not affect the baby. Thank you so much, and I hope to see you one day live in Kyiv. Thanks.